Hi class, this is my presentation on my evidence-based clinical change in practice. This is the slide that I would present in my defense. I want to explain to you what the process in the emergency department currently is, and then I will proceed to explain to you what the clinical change that I would be presenting. The current process in the emergency department is as follows. A patient comes in, they come up to the registration, they give them their name, their date of birth, they discuss their insurance, and they give a brief complaint such as, I have been vomiting. The triage nurse then will give the patient a set of different questions to figure out what their main complaint is, such as how long have you been vomiting? Do you have any abdominal pain? Have you had any diarrhea along with this? And they gain a couple different information and screens of the patient to decide an acuity level, meaning how many resources in the emergency department will this patient receive? Will they need blood work, an ultrasound, IV fluids, medications, and so on? Then the patient would get that acuity number, and either they would need to wait in the waiting room if there's no spaces for them to go into the main ED, or they would go into the main ED and wait. Sometimes that waiting time can be half an hour. Sometimes that time is 4 hours. It depends on the ED flow and capacity and how many patients are we taking care of, basically. So this system, as you can imagine, creates a lot of frustration with the patients. Things don't get done very fastly. The patients are ended up waiting. They don't see their nurse for hours on end. They just kind of go in this one straight line flow. So the idea behind my proposal is something called split flow triage. And that's where this slide and diagram comes into place. Split flow triage would look something like this. The patient would come up to the desk. They would get registered, name, date of birth, a little quick, why are you here? The triage nurse would ask the same kinds of questions, but unlike before, we would do a quick nursing assessment, take their vital signs, look at their heart rate, look at a brief look at the allergies that they're allergic to or medications that they're taking. And we would ask the same questions. How long has this been going on? Do you have any pain? We would still assign them that acuity level. The added thing that we're going to implement is right at that front process, there's going to be a physician in triage. That physician in this proposal would be a physician assistant or a nurse practitioner. The nurse practitioner would be kind of listening into the triage nurse and looking at the patient visually, looking at those vital signs, kind of collaborating with the triage nurse. How sick is this patient? What do we need to do? And it would be a joint decision. Do we need to get blood work on this patient? Do I need to order IV fluids and things to kind of get things started? And then that would happen right at the front. That patient would then hopefully go back into the ED if they're needing certain types of resources like the abdominal pain that I'm presenting. That abdominal pain would be a level 3, for example. That patient, meaning that they would need blood work, probably IV fluids, probably some medications, maybe possibly an ultrasound or an x-ray to see what's going on in the abdomen. So that patient would go back into the main ED, but those treatments would be ordered so that that ED nurse would be able to implement those treatments and say, okay, I know I need to go and get some blood work on this patient. I know I need to get a urine sample because it's a female and I have to make sure they're not pregnant and they need to go to CAT scan. They would be able to get all these things done. So the time frame of that patient being seen and treated starts becoming shorter. And that's because that physician in the front said, I want this done, and this done. So now I'm not waiting as long. And now that patient is getting taken care of. Now here's the second part of this process. It's going to be called the fast track. That second part of this proposal would look something kind of like the patient comes into the emergency department. Maybe this patient only needs some stitches. Maybe this patient needs a medication refill. Maybe they just need a social work. Those patients, we give an acuity such as a level 4 or a 5. So those resources are not as many resources. That patient only needs one or two things done. Maybe they just need another script. Maybe they need just a quick, let's put a couple stitches in. Those acuity levels, we consider them low acuity. And I know it's weird because it's a 4 and a 5, right? And you're thinking, well, that's a higher number. But those are considered a low acuity patients. So those lower acuity patients now, mind you, in the original method, go to the main ED with the other patients that need a lot more. So they're all lumped into one space. Now imagine if I created a second space for those 4s and 5s patients to go to, that they could get those things done really quickly. And that triage nurse and that physician that's in the front can order those things, talk collaboratively, work together collaboratively to get that patient in and out super quick. So now I have these two different systems now. Now I have this fast track area for these patients that only need a few different things done. And I have the patients that need a little bit more things to be doing in the main ED, but with orders placed. So now my time of waiting like 4 hours sometimes has now been dramatically decreased. The other great thing about implementing this dual system, if you will, which is called the split flow of triage, is those patients that are kind of coming in that are getting frustrated because they're waiting hours on end, or maybe they just need those quick little stitches, or they just need that medication refill and they can't get it at the doctor's office, whatever the reason may be. They get frustrated, they get agitated, and they end up leaving without being taken care of. That part costs the hospital a lot of money. They lose money on those patients leaving without being seen. That's where this proposal is really going to have a change. It's really going to be important to the stakeholders because they're going to want to know and understand how is this going to be cost effective? What am I going to gain from doing this proposal that you want? By doing this, I am helping to decrease the amount of patients that are left without being seen by shortening that time frame that they're going to have to wait, by speeding up the flow of the emergency department, by getting those patients that only need a couple different things in and out, and also getting those patients that need a lot more things done, seen faster. People are going to want to stay. They're not going to want to leave now, and they're going to be able to get the care that's important to them and could be medically important, right? So this is the proposal. I hope that you kind of understand what I'm proposing, that it's this two-part system. The flow will shorten up. It will be a nicer, quicker flow, and therefore save and actually help the hospital gain back that money that they're losing on those patients that are leaving without being seen. That's the important part. I hope you enjoyed this presentation.